I think you will find that after hearing Nikhil speak, your ideas of cancer screening may be a little bit different than before. So without much further ado, let's welcome Dr. Thekar.
Hello, my name is Nikhil, and I am a radiation oncologist, a medical director, and a researcher. I serve as the deputy editor of the journal AI and Precision Oncology, and today we'll be covering a brief overview of the role of AI in early cancer detection, a topic that is very near and dear to me as an oncologist. There are an incredible number of studies that have evaluated new AI tools for early cancer detection. Although we will only be able to cover a small sliver of these studies, I hope to build a solid foundation as we discuss some early clinical applications. So why should we detect cancer earlier? Well, when we find cancer earlier, there are fewer genetically mutated pathways and networks in those cancers, as seen here. For most patients, an earlier diagnosis means a higher chance of cure, less need for surgery, radiation, or systemic therapies like chemotherapy, and perhaps even a higher chance of maintaining a good quality of life after treatment. Right now, most precision cancer treatments target cancer when it's already advanced, but AI can be used to identify, predict, and even prevent cancer in earlier stages. But before we jump into those applications of AI in early cancer detection, a few words of caution. We need robust clinical trials of these new applications, and we need to grow expertise at the intersection of medicine, statistics, and computer science. We also need consistency in reporting findings according to consensus frameworks, and we need improved explainability and interpretability of AI model outputs. Now, keep these in mind as we explore these applications, and we'll be discussing many of these shortcomings throughout this talk. So first, what is artificial intelligence? Well, AI refers to computer programs or algorithms that use data to make decisions or predictions. To build an algorithm, we might create a set of rules or instructions for the computer to follow so it can analyze the data and make a decision. Now, machine learning, or ML, is a subdivision of AI that refers to when the algorithm teaches itself how to analyze or interpret data. You can see here that ML is just underneath and a smaller component of artificial intelligence. ML may pick up on patterns that are not readily discernible to us humans. And as these algorithms are exposed to new data, they can help us learn and improve. Now, deep learning is a type of machine learning, as you can see at the lower portion of the cartoon on the screen. And deep learning has a major benefit of detecting patterns in data with minimal human involvement. This will be a focus of many applications that we're going to discuss here. So in their most basic form, we can do deep learning with artificial neural networks, which are essentially complex, interconnected networks. Here's an example of a single hidden layer network that helps us predict the probability of lung cancer. First, the model takes in a patient's smoking status in pack years and in lung nodule size in millimeters, which you can see here in the box in red. Next, the hidden layer. Each node multiplies the values from incoming neurons by a weight, shown here as decimals, and then adds them all up. And finally, the results are passed to something called an activation function, which converts the output into a probability of cancer between 0 and 1. Now, we can have multiple learning cycles that are used to update the hidden layer weights to improve performance. In general, these models have ranged in complexity from shallow models, or less than 2 hidden layers, to more complex, deep learning models, such as those that are tens or even hundreds of layers deep. If you combine enough of these layers, you can represent arbitrarily complex relationships among data. Now, there are also some special deep learning architectures like convolutional neural networks, or CNNs. These allow the use of color images as inputted data. Let's take a look here at an example where we're trying to calculate the probability that a chest CT scan, which we see here on the left, identifies either a malignant nodule, a benign finding like a granuloma, or just a normal scan. This CNN takes in as its input the CT data set, which we see here on the left and in this box here on the left. The inputted data are processed by a series of kernels, which slide over image color channels and extract features like edges and color gradients. The downstream fully connected layers, which I have in this box now here in red in the center portion of this picture, resemble those of the artificial neural network that we just saw in the previous slide. We still have an activation function like we did in the previous example, and then the output gives us the probability of malignancy, or a benign finding, or even just a normal finding. I've listed a few notable and popular CNN architectures here, which have demonstrated remarkable accuracy in computer vision tasks. You may hear a few of these names in the examples that we'll explore. There's also a more advanced vision transformer that uses a self-attention mechanism to process images more globally rather than locally, as is typical in CNNs. Here's an example of an inputted image here of a blood cell, which we can see on the left. And this model can localize the cell and classify the cell into one of several blood cell types. We can see the classifications on the right side of the screen. Now, the computation cost of this self-attention layer can be expensive, especially for high-resolution inputs. So it's currently suitable for smaller spatial dimensions, but as computational capacity improves, we're going to continue to see innovations in this area. And we're going to cover a couple of key examples that have been using vision transformers. So how do we commonly assess the performance of these algorithms? Well, in this brief talk, we'll be using something called receiver operating characteristics, or ROC curve, and in particular, the area under the curve, or AUC. These curves characterize the model's trade-off between sensitivity and specificity, and we're in general looking for models that have an AUC closer to 1.0 or 100%, since a score of 0.5 or 50% would be no better than chance. So these AI technologies, of which we're starting to build a foundation, can be applied to a wide array of data types in oncology. Natural language processing, for instance, can be used to evaluate clinical and administrative data from electronic medical records, or EMRs. Computer vision can be used on diagnostic and treatment planning images, such as radiology, digital pathology, pictures, and videos. Numerous data science algorithms can also be used on biospecimen data, such as genomics, proteomics, metabolomics. And then we can also use machine learning on data from digital health sensors like wearables. Ultimately, we can integrate all of these data types into what we call a multi-omic or multimodal set of models. We're going to discuss that towards the end of this discussion. All right, so let's put this all together and leverage these tools to detect cancer earlier. We certainly won't have an opportunity to cover them all, but we'll choose a few examples to illustrate these applications. So let's start with a couple of examples of how machine learning is being used in the medical record to improve risk stratification and screening. In general, screening is a one-size-fits-all approach, but can we improve screening through better risk stratification? Would that potentially help us to better select patients who need screening? The current standard for lung cancer screening is to do an annual low-dose CT for lung cancer screening for eligible adults, as outlined here at the top portion of the slide. Now, in 2021, only about 6% of those who were eligible were actually screened with these low-dose CT scans. Now, this is possibly due to a lack of access to screening centers, poor documentation of smoking status, insufficient time during physician and provider visits, among many other causes. So these investigators here in this study, they trained a CNN model that incorporated minimal EMR data elements such as age, sex, current smoking status, plus chest X-ray data from over 10,000 patients on two major clinical trials called the PLCO and the NLST. Interestingly, the CNN performed even better than Medicare's criteria for predicting 12-year lung cancer incidence. And this is just from EMR data and chest X-ray. Now, just earlier this summer, we saw headlines from Nature Medicine about AI being able to predict future pancreatic cancer risk. Pancreatic cancer is a low incidence but very aggressive cancer with high mortality. So these investigators in the study, they trained, developed, and tested a model on a sequence of ICD disease diagnosis codes, as well as billing codes. They initially used a Danish cohort of 6 million patients and then cross-applied that model to 3 million patients from the US Veterans Affairs System. The machine learning model outputted the prediction of pancreatic cancer within 36 months, as you can see in this red box here at the bottom of the screen. This initial Danish cohort reported actually a very impressive AUC of 0.88, though with a slightly lower performance when they applied that same model to the US dataset. So imagine how such studies could benefit from not just machine learning of EMR data and billing and coding data, but also incorporating more data sources such as medications, labs, clinical notes, imaging scans, and also population-wide genetic profiles. Now, most of the current focus of AI in medicine has been in the use of AI for medical imaging, which broadly includes radiology, pathology, and images and videos from other procedures like endoscopies, skin cancer images, and others. In fact, of the nearly 700 AI-enabled medical devices, and you can see a listing of them here, approved by the FDA, 77% of them are for radiology. That begs the question, why radiology? Well, the migration from radiographic film to digital scans has yielded major for imaging research. Radiology includes many modalities. That includes things like CT scans, nuclear medicine such as PET, MRI, ultrasound, and many more. And the term radiomics refers to quantitative methods for analyzing radiology images. So a common use of AI and machine learning has been in the area of breast cancer, and especially mammograms used to identify breast cancer. Now, although we recommend screening mammograms for eligible women, mammograms have a high false positive and negative rate of nearly 12%. So this can lead to overdiagnosis and overtreatment, sometimes underdiagnosis, and also psychological impact and cost. So this team from MIT developed a new machine learning model called Mirai that incorporates both imaging factors with non-imaging risk factors, such as age, hormonal factors. So take a look at this model here in the red box here in the center. This model takes in standard views of a mammogram, followed by 4 modules that ultimately predict a patient's risk of breast cancer for each year over the next 5 years. Impressively, they found that 41% of patients who would develop cancer within 5 years were identified as high risk by their model. And that's compared to only 23% that were identified as high risk by the more commonly utilized Tyrer-Cuzick model. Google's DeepMind also created an AI algorithm to identify nodules on mammograms. This AI system achieved a very significant reduction, actually, in both false positives and false negatives, especially in the US cohort. And it outperformed 6 human radiologists. When mammograms were double read to minimize errors, the AI system maintained comparable performance while significantly reducing the second reader's workload by 88%. Now, this has major implications on resource availability, efficiency, as well as triaging the radiology workflow. So let's actually focus on the last portion and that last point about triaging the radiology workflow for just a moment. This team from Karolinska Institute looked to do exactly this with mammography. Their algorithm calculated an AI detector score. The lower the score, the lower the predicted risk of breast cancer. When the lowest 60% of AI scores were excluded from even any radiology reviewing those mammograms, 0% of those cases resulted in breast cancer. On the high end, the top 1 or even 5% of AI scores, incredibly, the AI detected even more cancers than the radiologist. So very impressive findings. So the question is, can we repeat this in other cancers, such as lung cancer? Well, there are more than 1.5 million lung nodules identified in patients in the United States each year alone. But this can be difficult to tell if these nodules are malignant or benign, as there's many false positives and negatives on these CT scans. Now, we also know that low-dose CT for lung cancer screening improves lung cancer mortality by nearly 20 to 24%, based on a couple of major clinical trials, including the NLST and the Nelson trials. So this begs the question, can we build a deep learning model from these low-dose CT scans to better predict an individual's risk of developing lung cancer in the future? Well, we'll first delve into some groundbreaking work by this team from Google. They published an end-to-end solution that starts with nodule identification all the way on the left side of the screen, and goes all the way through classification and risk prediction, all within a single workflow. Their deep learning model utilized both current and prior CT scans of a patient to assess lung cancer risk. And impressively, they demonstrated a state-of-the-art AUC of 94.4%. Their model even surpassed the performance of 6 radiologists when no prior CT scans were even available. So this is yet another example of how AI-based models could lead to wider adoption of more effective screening practices more globally. Another group of investigators from MIT similarly hypothesized that a deep learning model could assess the entire low-dose CT dataset to predict an individual's risk of developing lung cancer. But this time, they did not require additional demographic data or even additional clinical data. So this study begins first with radiologists annotating lesions on low-dose CT scans using the MD.AI software, as you can see here with these purple bounding boxes. They first extracted features from the low-dose CTs via a pre-trained 3D ResNet 18 encoder. You can see the architecture here at the top of the slide. Ultimately, they calculated the cumulative probability of developing lung cancer within 6 years. That's the red box here on the right side. They trained that same algorithm 5 times, and they averaged those risk predictions to create their new algorithm, which they called Sybil. So how does the algorithm work practically? On the bottom left here, we have a 73-year-old gentleman with an 80-pack year smoking history. He was found to have a barely perceptible less than 6 millimeter nodule in the left upper lobe, shown here in blue. This would have triggered a recommendation for a 6-month scan for follow-up, and it fell within the 65th percentile for risk by the Sybil algorithm, so on the higher end. Unfortunately, the patient missed the recommended screening and 2 years later was found to have this. This is a 1.8 centimeter now solid spiculated nodule that was biopsied and now proven to be non-small cell lung cancer in the same place as the performed exceptionally well, with an AUC of between 0.86 to 0.92 for predicting lung cancer at 1 year. And that was even in 3 multinational and multi-institutional cohorts seen at the top of the imaging screen here. What's amazing here is that Sybil can actually just run in the background at a radiology reading station as soon as CT images are available, without needing to input demographics or clinical data, and without the radiologist even needing to annotate an area of interest. Interestingly, the investigators also found that the analysis of just the CT images themselves could actually predict clinical variables, such as smoking duration, weight, race, smoking status, sex, family history, and age. So with such improvements that we're seeing in diagnostic performance of screening methodologies or mammograms and low-dose CT scans, the general diagnostic workflow for screening studies may evolve in this near future. For common screening procedures like mammograms or low-dose CT, we might be able to start to set a threshold for risk and confidence a priori. If the predicted risk, for instance, is low and the confidence of the AI model is high, then could the AI's algorithms analysis actually serve as a primary read, with a physician as a secondary reviewer? Conversely, if the risk is high or the confidence in the AI model is low, could those cases actually then be escalated for specialist physician review to supplement the AI evaluation? So these innovations we're seeing here on mammograms and CT scans are also occurring in more advanced imaging modalities. For instance, PET-CT scans are commonly used for staging and surveillance of lung cancers. In general, for this type of lung cancer, the presence of specific mutations helps us direct treatment options. If there's an EGFR mutation, for instance, we may start with a tyrosine kinase inhibitor. If the PD-L1 is positive, we may consider an immune checkpoint inhibitor or a combination of these. Now, at this time, mutational analysis is done on biopsy tissue, which is obtained via an invasive biopsy or invasive surgery. Now, in this thought-provoking study by Mu and colleagues, they used an unsupervised hierarchical clustering of features in PET scans to identify associations between specific mutations and PET imaging features. So patients with a higher deep learning score experienced longer progression-free survival when they were treated with targeted therapies or immunotherapies. And so now what we're seeing here is that we can actually take features from advanced imaging like PET, and we can start to predict biomarkers that can be used to direct treatments. This is likely just the tip of the iceberg here, and these techniques are really going to continue to evolve very rapidly in the coming years. These AI algorithms are also showing significant promise in prostate cancer, which is the most commonly diagnosed cancer in men. We're seeing numerous models on the use of AI in imaging and pathology analysis, as I've highlighted here. We won't be able to cover all of these, but let me briefly mention just a couple of examples. So the first is by Shelb and colleagues here on the left. They developed a deep learning model using multiparametric prostate MRI scans. They used a UNet architecture to create an automated segmentation map of the suspicious region, which you could see sort of in the heat map in that image on the left. Now, this model achieved comparable performance to the typical PI-RADS assessment that we use for prostate cancer. And impressively, the deep learning model could actually increase positive predictive value by almost 20%. Now, on the study on the right, Wang and colleagues found that their deep learning algorithm that was trained on MRI scans was able to distinguish pathologically confirmed prostate cancer from benign conditions. Incredibly, they actually compared deep learning to non-deep learning machine learning techniques, and they saw really state-of-the-art performance of these deep learning models. We're also seeing some incredible results with AI interpretation of pathology slides. Pathology is a study of disease, and pathologists study pathology slides to make a final diagnosis. Improved technology has now allowed for whole slide imaging, where we can actually take high-resolution digital images from scanned pathology slides. Take a look at the left side of the screen here. This is where you can see various vendors that offer whole slide imaging systems. And on the right, we see an example of an AI algorithm reading a pathology slide and outputting the risk of, in this case, specific types of skin cancer. In 2021, the FDA authorized the first AI-based software to detect prostate cancer called Page Prostate. In their paper, this model resulted in the identification of 4 additional patients whose diagnoses were upgraded from initial benign or suspicious up to malignant. Impressively, this AI-based technology provided an estimated 65% reduction in diagnostic time, which again can have major implications on workflow and pathology resources. As these algorithms improve, the question is, could automated AI evaluation of histologic slides forego full histopathologic review, especially in low risk but high confidence scenarios, similar to what we were looking at with mammograms or CT scans? And just recently added to arXiv is a phenomenal new 632 million parameter digital pathology foundation model that's been trained on 1.5 million H&E stain whole slide images from really a diverse set of tissues, ranging from breast cancer to adrenal gland tumors, as seen here in the middle of this slide. The model uses cutting-edge transformer technology, something that we covered earlier in the talk, with self-supervised learning, and achieves really exceptional AUC values for things like biomarker predictions, subtyping of cancers, and detection of cancers. Computer vision is also improving for non-radiology and non-pathology pictures. This is a great example here. So a deep learning algorithm was trained on 60,000 cervical images from women in Costa Rica. And the deep learning algorithm outperformed human experts with an AUC of 0.91. This new method has the potential to be of major value in low resource settings and is very easy to perform. Amazingly, healthcare workers just simply can use their cell phone or similar camera to take a picture of the cervix during this evaluation. And even just those pictures can be used for deep learning analysis. As computational capacity has improved, we're also seeing deep learning used during endoscopies, such as colonoscopy. In general, colonoscopies have been the gold standard for colorectal cancer screening, but about 25% of colorectal neoplasia may be missed at screening. AI algorithms can enhance this process through real-time polyp detection, like in boxes seen here on the right. This can actually increase adenoma detection rate from 25% up to over 36%. And imagine that AI can become a co-pilot for endoscopists. So published just a few days ago is a systematic review and meta-analysis of 33 trials, which shows impressive improvements with AI during colonoscopy. Amazingly, adenoma detection rates improve significantly, and it's these adenomas that are most likely to progress to cancer. We'll need to see this technology continue to be able to classify pre-malignant from non, something called computer-aided diagnosis, and there's a lot more to come with this impressive technology. We're also seeing new tools that can detect not just skin cancer, but a wide range of skin pathologies. This team from Stanford created an AI tool for diagnosing skin cancer based on more than 129,000 clinical images. On the left here, you can see over 2,000 diseases organized by visual and clinical similarity. And on the right, you can see malignant and benign images from 2 of these classes. So how does the model work here? Well, firstly, there's an image of a skin lesion here, for example, a melanoma that's taken in on the left side of the slide. And that image is sequentially warped into a probability distribution. The investigators here used a fine-tuned Google Inception v3 CNN architecture that in turn had been pre-trained on the ImageNet dataset. And amazingly, they, for instance, are able to output a probability of, say, 92% that this image represents malignant melanoma. And as we can actually see here, high-dimensional data on the last hidden layer in the CNN, we can actually see colored point clouds here that represent different clusters of disease categories, from squamous cell carcinoma to basal cell to melanoma to even benign findings. This model actually achieved comparable results to 21 board-certified dermatologists, which is a really impressive feat. However, it was later found that less than 5% of images in the data set that was used to train this model pertained to darker-skinned individuals. And that did draw some criticism about reproducibility and external validity, especially on other populations of patients that may be more enriched with darker skin lesions. The lack of prospective trials and external validation of these models does need to be addressed before we can clinically deploy these models. Okay, so far we've been seeing organ-specific testing. So for instance, a single low-dose CT scan that's used exclusively for lung cancer screening. But what if we could instead move to a multi-cancer early detection test that could detect dozens of cancers, maybe all from a single blood draw? How could AI help to make that possible? Well, when tumor cells die, grow, or progress, we can see a change in blood biomarkers such as proteins, metabolites, lipids, fragments of cell-free DNA, circulating tumor cells, or even circulating tumor DNA. We can take a peripheral blood draw to sample and detect these changes during screening, after treatment, or even over time. Grail's Galleri test takes a blood sample and recognizes differences in something called DNA methylation patterns between cell-free DNA. Think of these methylation patterns as like being unique fingerprints for each tissue and cell type, which you can see here on the left side of the screen. Cells with cancer have a different pattern than cells without cancer. Galleri checks over 1 million methylation patterns in cell-free DNA and applies machine learning and pattern recognition to identify abnormal methylation patterns that could signal the presence of cancer. We're actually going to be hearing a lot more about some exciting innovations in multi-cancer detection from Dr. Tom Beer of Exact Sciences later this afternoon. So what does the future then of early cancer detection potentially look like? Well, we'll see synergism between humans and AI, where many applications will be improved by having humans plus AI rather than one alone. We'll see effective applications in clinical decision support and remote monitoring with Internet of Medical Things. But importantly, we'll see a future where there are models incorporating multimodal data. And we'll also need to become more interpretable as well. And these models will need to have explainability built into it. And we'll need to also incorporate some form of digital twin technology. So let's just briefly explore these last three quickly. Using a single type of data, such as imaging or genomics, in many of the applications that we've discussed, may, however, overlook interactions with interdependent data sources, such as epigenomics or proteomics or clinical information. These so-called multi-omic models may better describe tumor landscape and improve diagnostic precision rather than just using a single type of data alone. So here's an example of a multimodal model from the Broad Institute of Harvard and MIT. The model integrates pathology slides and molecular data to stratify patients into low and high risk, as seen in the red box here at the bottom right. Such models are not yet ready to be incorporated into a more expansive data set, but imagine now starting to incorporate CT imaging and EMR data, which may further improve the model's performance. So this starts to get at a very important future need, which is the ability to interpret and then explain the results of these models. So, exactly why does the algorithm make the prediction or calculation that it does? And how can not only we understand that calculation, but how can we then explain that to our patients? This group of researchers developed a biologically informed deep learning model that stratifies patients with prostate cancer by treatment resistance and evaluates molecular drivers of treatment resistance. This model processes genomic changes in the prostate cancer and then determines and ranks the importance of different mutations in explaining the outcome, so that thereby helps us to better understand the roles of these genes by having a deeper understanding of the biology and the ranking of their contribution to the outcome. And finally, the future may incorporate digital twin technology that will link a physical model, like a patient with a specific cancer, to a virtual counterpart. Now, this innovative approach leverages data from multimodal data sources like EMRs, imaging, pathology, multiomics, wearable sensors, and other data sources to simulate personalized patient care inside of a computer to then improve diagnostic accuracy, predict and risk stratify patients, and even potentially test outcomes of therapies in silico through data analysis and machine learning. This technology could potentially be a very useful substrate to those looking to even identify those that are at risk of developing cancer early. So thank you so much for joining me on this overview of what is a rapidly shifting landscape of the use of AI in early cancer detection. We will have an in-depth review of this topic in the journal AI in Precision Oncology. And if you're interested in further discussions or opportunities to collaborate, feel free to reach out to me anytime on LinkedIn. Thank you very much.